In this video, we will talk about fractures involving the clavicle bone, and we will explain them in details, including the anatomy of the clavicle. So if you want to skip to other parts of this video, you can by using the time codes which will appear on your screen right now, or you can by using the video chapters available in the video description. And this video will be the beginning of a new class. It's called the Shoulder and Arm Trauma Masterclass. So in our talk about the clavicle fractures, we will start with an overview. So fractures of the clavicle are common, and they are accounting for up to 10% of all fractures in adult patients, and they are the most common fracture in children. And these fractures result from either a direct blow to the clavicle or from forces that are transmitted after a fall on the outstretched hand or a fall on the shoulder. Moving on to talk about the anatomy of the clavicle. So the clavicle is an irregular S-shaped bone that you can see in the 3D model in this picture here. And its function is to hold the shoulder joint in a functional position away from the chest wall. And the clavicle connects the manubrium of the sternum, which is here in this picture, to the acromion of the scapula. And the acromion is right here. And it connects with the manubrium through the sternoclavicular joint, which is the SC joint, and it connects with the acromion through the acromioclavicular joint, which is here, which is called the AC joint. And the clavicle is stabilized by the coracoclavicular ligaments, which include the conoid and the trapezoid ligaments. And the coracoclavicular ligaments are here. They connect the coracoid process of the scapula, which is here, to the clavicle in here. So those pictures here shows the surface of the right clavicle. The upper picture is a superior view, and the lower picture is an inferior view of the right clavicle. So we have the medial end, which is this end, where it connects with the sternum, and we have the other end, which is the lateral end, where it connects with the acromion. And from the superior view, we can see that the clavicle surface is smooth compared with the inferior view, and we can see the conoid tubercle where it connects with the conoid ligament. And on the inferior surface, we can see the deltoid tubercle where it connects with the deltoid muscle, and we have the trapezoid line and the conoid tubercle, which is also seen on the superior view, and that is where it connects with the trapezoid and conoid ligaments respectively. And we also have the rhomboid impression. Those pictures here shows the areas of muscle attachment of the right clavicle also. The upper picture is a superior view, and the lower picture is an inferior view also. And the same applies. So the medial end here is where the clavicle connects with the sternum on both pictures, and the lateral end is where it connects with the acromion in both pictures. And anteromedially here, we can see that the clavicle is connecting with the pectoralis major in both views, and posteromedially, we can see that the clavicle is connecting with the sternocleidomastoid on the superior view and the subclavius muscle in the inferior view. And anterolaterally, we can see that the clavicle is connecting with the deltoid muscle on both views here. And posterolaterally, we can see that the clavicle is connecting with the trapezius muscle here and here. We also can see that on the inferior view, the clavicle is connecting with the sternohyoid muscle on the medial side. Now let's talk about the classification of clavicle fractures. So clavicle fractures are classified according to their location on the clavicle. So we have the middle third fractures, which account of about 75% of all clavicle fractures. So the middle third fractures are fractures that involve the middle third of the clavicle, as you can see in this picture. And we have the lateral third fractures, which account of about 22%, and they involve the lateral third of the clavicle here. And we have the medial third fractures, which account of about 3% of all clavicle fractures, and they involve the medial end of the clavicle, as you can see here. Now, the lateral third fractures, which are those? So the lateral third fractures are subclassified according to the Neer classification. So again, clavicle fractures are generally classified into medial third fractures, middle third fractures, and lateral third fractures. And the lateral third fractures specifically, which are that happen here, they are subclassified into different types according to the Neer classification that we will explain here. Now let's talk about the Neer classification. So this is the most commonly used classification for the lateral third clavicular fractures, and the Neer classification classifies these fractures into 5 types according to stability, degree of displacement, and treatment recommendations. So we have type 1 and we have type 2, which is subclassified into type 2A and B, and then we have type 3, type 4, and type 5. So starting with type 1, type 1 is where the fracture line is lateral to the coracoclavicular ligaments. So here we have the coracoclavicular ligaments, and the fracture line is here lateral to these ligaments. And we have minimal displacement, as you can see in this picture. There is minimal displacement that happened to these fractures, and the coracoclavicular ligaments, as you can see in these pictures, are both intact. And since the coracoclavicular ligament is intact, then this is a stable fracture that requires non-operative treatment. And by non-operative treatment, I mean sling immobilization. So we apply a sling to the fracture and we keep it for about 2 to 3 weeks until fracture heals. Moving on to type 2A, this is where the fracture line is medial to the coracoclavicular ligaments. So remember, the type 1 is lateral to the coracoclavicular ligament. Now the type 2A is medial to the coracoclavicular ligament, as you can see in this picture here. So this is the fracture here, and this is the coracoclavicular ligament here. And with this fracture, there is significant displacement, as you can see in this picture. There is significant displacement because this fracture fragment is pulled down by the weight of the shoulder, and the other fracture fragment is pulled up by the sternocleidomastoid muscle action, and this leads to displacement that happen in this type of fracture. And the coracoclavicular ligaments, the conoid and trapezoid, are both intact, as you can see in this picture, and this is an unstable fracture because there is a great degree of displacement that requires operative treatment in most of the cases. Now let's talk about the type 2B. So the fracture line in type 2B is between the coracoclavicular ligaments, resulting in a torn conoid and intact trapezoid. So this time, the fracture line is between the coracoclavicular ligaments. Here we have the conoid, and here we have the trapezoid. And since the fracture line is between them, this will lead to one of them being torn, which is the medial one, which is the conoid, and the trapezoid is still intact. And the medial clavicle is significantly displaced because of the muscle pull of the sternocleidomastoid, as we mentioned, and the other fragment is displaced downward because of the weight of the shoulder. And this is also an unstable fracture that requires operative treatment. So now again, the type 1 is lateral to the ligaments. The type 2A and B are happening one medial to the ligaments and the other one is between the ligaments. And now the type 3 is happening lateral to the ligaments again. So in type 3, the distal clavicular fracture is extending into the acromioclavicular joint, meaning it is an intra-articular fracture. So the fracture line, as you can see here, is extending to the AC joint. This is here the AC joint. And there is minimal displacement happening because the ligaments, the trapezoid and conoid, both intact, so minimal displacement. And yeah, so coracoclavicular ligaments are both intact, and it's a stable fracture, and it requires non-operative treatment with a sling immobilization. Moving on to type 4. Type 4 is when the distal transverse clavicular fracture is involving the physis, which is a Salter-Harris type 1 fracture. And this type of fracture happens in children because they have a physeal plate that is easily to fracture. And as you can see here, the fracture is transverse and it happens medial to the coracoclavicular ligaments, and it's a Salter-Harris type 1 fracture. The medial clavicle is superiorly displaced by the action of the sternocleidomastoid, as we mentioned, and the other fragments is pulled down by the weight of the shoulder, and the coracoclavicular ligaments are both intact, as you can see them here, and this fracture is considered stable and it requires non-operative treatment. Moving on to type 5, this is the last type, and it is a comminuted fracture in the distal clavicle, as we can see in this picture here, and the medial clavicle is significantly displaced by the same mechanism, so the medial fragment is built up by the sternocleidomastoid action, and the distal fragment is pulled down by the weight of the shoulder, and the coracoclavicular ligaments are both intact and attached to the inferior fragments that you can see here. And it is an unstable fracture that requires operative treatment. Now let's talk about the clinical features of the clavicle fractures. So the patient with these fractures present with a history of fall. So they tell you that they have fallen either on their shoulder or on their outstretched hand, and the patient complain of pain and crepitus at the fracture site, and the patient arm is adducted to the chest wall and supported by the other hand to prevent movement. So basically the patient will hold their arm adducted to the chest and supported by their other hand to prevent movement. And also in the middle third fractures, and also in some of the lateral third fractures, the lateral fragment is pulled down by the weight of the arm, as we mentioned before. So lateral fragment here pulled down by the weight of the arm, and medial fragment is pulled up by the muscle action. This fragment here, the medial fragment pulled up by the sternocleidomastoid action, leading to significant displacement, depression, and shortening, and subsequently deformity that is obvious. So always look for this deformity and try to compare both shoulders looking for it. And also look for tenting skin over the displaced fragment. So when the fragment would go to the skin, it would cause a tent type of shape. So look for this tenting shape because it's an indication for urgent reduction, because this fragment might pierce the skin and the fracture would become an open fracture. And it is important to check the brachial pulse of the patient to make sure there is no vascular injury, and also auscultate the patient's chest, searching for pneumothorax, so searching for hyperresonance sound of the pneumothorax. That is because this fragment might go ahead and injure the subclavian artery, leading to vascular injury, so that's why you will check the brachial pulse, and also you will auscultate the chest looking for a pneumothorax that resulted from the fragment of the clavicle piercing the pleural space. Now also comparing the injured and uninjured sides gives you an idea of the severity of displacement, and excluding a major rotator cuff tear is possible by active shoulder abduction to 45 degrees, although it is painful. So ask your patient for a shoulder abduction until 45 degrees, although it is painful, just to exclude the rotator cuff tear. And in addition to the other trauma investigations, you must send your patient for radiographic analysis that requires an anteroposterior and a 20-degree cephalic tilt, clavicle x-rays, and other views may be needed also to diagnose the fracture and the associated injuries. And CT scanning may be needed if the fracture is in the sternoclavicular joint. So if the fracture was here in the sternoclavicular joint, then CT scanning may be needed to evaluate the fracture and to look for associated injuries to the mediastinum. Now, in the emergency room, closed reduction is not recommended because there is high risk of damaging the adjacent structures. The adjacent structures being the brachial plexus, the subclavian artery, and the pleura. And the figure of 8 bandage is not recommended. The best solution is to initially immobilize the fracture by a sling, which looks like that. Moving on to talk about the definitive management. So in middle third fractures, which are the most common fractures to affect the clavicle, so the undisplaced middle third fractures are treated non-operatively with sling immobilization for 2 to 3 weeks, and the patient is advised to mobilize the limb as soon as pain allows. So we advise them to mobilize and exercise the limb as soon as possible, including mobilizing the fingers, the elbow, and the shoulder to prevent stiffness from happening. Now, regarding the displaced middle third fractures, they are either treated operatively or non-operatively, depending on the degree of displacement. And internal fixation is used more nowadays to treat those fractures, especially the ones with severe displacement, comminution, or shortening. So the idea of the operative treatment is that we first reduce the fracture and then we internally fixate the fracture by either plates and screws or by some type of a screw or an intramedullary device. So this picture here shows a common method to fixate these fractures by a plate and screws, and this picture here shows a comminuted fracture of the middle third that is treated with an intramedullary device that you can see in the second picture, which is here. Now let's talk about the definitive management of the lateral third fractures. So we already talked about that in the Neer classification, but here we will give you a general idea. So the undisplaced lateral third fractures that are associated with intact coracoclavicular ligaments are treated non-operatively with a sling immobilization for 2 to 3 weeks. And displaced lateral third fractures that are associated with disrupted coracoclavicular ligaments are mostly treated operatively due to the high non-union rates and the mal-union rates associated with the non-operative treatment of these injuries. So they are better treated operatively, but some specialists would treat them conservatively and reserve the surgery for the patients that have symptomatic non-union. Finally, regarding the medial third fractures, which are rare, those are managed non-operatively unless the fracture is displaced and threatens injury or injured a mediastinal structure, then we have to treat it operatively. Now, regarding the indications for surgery in clavicle fractures, those include an open clavicle fracture, an impending skin tenting injury, and severe displacement or severe comminution or symptomatic non-union. and the average time to heal after surgery is about 6 to 8 weeks, while without surgery it would be about 2 to 3 weeks. Finally, let's talk about the complications. So early complications include pneumothorax and subclavian vessel injury and brachial plexus injury, and all of these are rare. Late complications include non-union. Non-union occurs in 10% of displaced fractures, and risk factors for non-union include comminution, displacement, elderly patient, and female sex. And symptomatic non-union treated with internal fixation and bone grafting if needed. And symptomatic non-union is when there is pain associated with the non-union. Late complications also include malunion. Malunion occur especially when there is shortening displacement and it is for more than 1.5 centimeters. And finally, the late complications also include stiffness of the shoulder, which is a common type of complication but a temporary one that resolves with exercising the shoulder joint. And with that, we reach the end of this video. Thank you guys for watching. Please support this video by giving it a like and commenting your ideas and questions. And this video is about a figure class. It's called the Shoulder and Arm Trauma Masterclass. You can check it out if you want.